Hi everyone, welcome. Great to have you all here today, and we're looking forward to sharing some of our health economics and outcomes research expertise with you, and hopefully you'll find it useful. So yeah, I think we'll just do some quick introductions. So I'm Lucy, one of the health economists at Hardian. You'll recognise me from the videos that will be put on. I don't know if they already are available. If not, will be available on the HDR UK website, where I'll be embarrassing myself talking through some introduction to health economics. And as you'll hear on the video, I've been at Hardian for a couple of years now. And prior to Hardian, was working in industry and academia, focusing on the economic evaluation of pharmaceutical interventions. And since I've joined Hardian, we've really been interested in bringing the kind of gold standard practice methods that are set out for the evaluation of pharmaceutical interventions and bringing those methods to the digital health medical software device space, and looking at how we can learn from those best standard practices when evaluating these new technologies. So yeah, I'll pass on to Trishul. Quickly introduce himself.
Hi everyone, my name is Trishul Budna, and I've got about 15 years worth of experience in the health economics and outcomes research space. Got a PhD in economic evaluation and spent quite a bit of time focusing on supporting the pharmaceutical industry with things like NICE submissions for pharmacological interventions. But more recently, been supporting Hardian with trying to get more of the kind of medical devices and digital health technologies through those kind of pricing and reimbursement pathways, and to get traction in, for example, the NHS or with NICE as well. So building those kind of economic models, budget impact models that we're going to be talking about today. And yeah, nice to meet you all, and I'll pass back to Lucy.
Right then, so let's get started. Just before we do, this is the agenda for today. So we've got about 3 hours to play around with, which is a fantastic amount of time. And kind of most of the session, half of it, will be taken up by us giving a kind of mini lecture on health economics, something similar to what you would experience if you were to do like a master's course in health economics, only we won't be charging you 20 grand for this course. And then after that, we will go through a current kind of client project that we have at the minute. Hopefully that will demonstrate and really put into practice what we've been talking about through the first half. And then finally at the end, we've got a good amount of time for some Q&A. But as Rosie said, we will be taking questions throughout the session as well. The Q&A at the end really is just for any questions that you've forgotten to ask or didn't have time to, or just more general questions that aren't necessarily, that might not be related to anything that we've discussed. I think in terms of what we're going to be covering in the health economics lecture, the focus is on health economic evaluation and the generation of health economic evidence for the adoption of digital health technologies. The only thing that we won't be covering is the reimbursement of the economics of reimbursement models. But this is something that we can always kind of follow up with in a later session or emails one-to-ones for those who are interested. So let's get started. So for those of you that don't know or who are unsure, health economics is concerned with the efficient and equitable allocation of resources within healthcare systems, where there are infinite demands for health. People are always getting sick, but we have a limited amount of resources to meet these demands. And so health economics really tries to solve this problem and by balancing, infinite demands with these finite resources, with the ultimate aim to improve population health. And then we have health economic evaluation, which is really, so health economics is more the idea, the thing we want to do, but then the health economic evaluation really is the action of health economics, where we take a comparative analysis of all alternative interventions and we compare them in reference to their cost and consequences. And these evaluations really then empower decision makers or policy makers when making decisions on where to allocate resources to ultimately, as we said, improve population health. And health economics, really is important because, as I've said, it's an excellent way for us to analyze scarce resources and make decisions on where best to allocate our resources, and also to kind of systematically analyze and take stock of all the opportunities and options that we have available to us. And also the economics perspective is also very useful. Don't want to be kind of tooting our own horns too much, but it's really beneficial because we can not only consider the financial kind of consequences of decision making, but also the non-financial elements and trying to quantify the non-monetary aspects of decision making, for instance, quality of life. And then overall, it really is just useful to have a formal quantification of the benefits and costs, because without this, it can be quite hard to limit uncertainty and risk as much as possible when making these decisions.
And just to add to that slightly as well, I think health economics is moving into accounting for more societal perspectives as well. So accounting for, the productivity of the individuals that is being sacrificed due to lack of interventions or appropriate interventions. So health economics, in summary, is not just about the financial implications. A lot of people think that, economics is focused on that kind of accounting side of things. But actually it's quality of life, it's length of life, and also more societal impact. It's also things like caregiver burdens as well. When there's a burden on the patient, that gets strained on the rest of the family and the caregivers, and that impacts their productivity as well. So health economics, the branches of health economics can reach quite deep beyond the patient as well.
You'll often hear health economics in the context of health economics and outcomes research, and these really are health economics and outcomes research to HER teams. You'll hear the term a lot, and these are kind of the departments or teams of analysts that are dedicated to conducting economic evaluations in life sciences. And HER really is concerned with assessing the value for money of drugs, new interventions, AI devices, and also the affordability of these interventions. Now, just because an intervention may be providing good value for money, it doesn't necessarily mean that it's going to be affordable to the budget holders. So the economic kind of evaluation really needs to be kind of accounting for those two key aspects. And kind of throughout the presentation, we're going to be referring to kind of best practice gold standard methods. And these are set out by the Professional Society for Health Economics and Outcomes Research. And ISPOR is really like the big international powerhouse for HER, and they set out the guidance for kind of best methods that we can use when it comes to conducting health economic evaluations. And so really trying to, at the minute, with our ongoing work and going forward to apply these methods to the evaluation of digital health technologies and software devices. But as you'll see, kind of as a kind of running theme, will be a running theme as we go through the session today, is that the ISPOR guidance really is set up for the evaluation of pharmaceutical interventions, pharmacoeconomics. And this is kind of becoming problematic in places when it comes to evaluating, or when it comes to applying the ISPOR methods to digital health technologies, because obviously the benefits that digital health technologies have to offer differ slightly to the benefits of pharmaceutical therapeutics.
I think one way it differs is in terms of the level of data available. I think we're going to go into so much detail on this later, but it's clear that the pharmaceutical industry has a whole wealth of data that they can play with. They have 3 to 4 year clinical trials. They have billions of pounds behind them. And I think that that is appreciated by the reimbursement bodies. They accept that digital health technologies have, and the companies that run them, have shorter runways, and they provide more immediate solutions. So should we be running such long studies to validate the data? In theory, yes, we should. But and current guidance is, in terms of health economics, is leveraged around great data. But we do need to kind of push towards a direction where, you know, it's more acceptable to have less data. And hopefully Lucy and I will be writing some papers and working with ISPOR to try and get them to understand that the level of evidence that's expected at the moment is perhaps a little too high, and there's got to be some meeting in the middle there.
So now we've kind of gone through that brief introduction. We'll get into kind of how we go about doing these evaluations. And I'm sure most of you have kind of encountered the PICO population intervention comparator and outcomes framework before. It really is a framework used across kind of clinical medical research to frame a research question to ensure that the answer is developed kind of in a concise and direct manner. But in health economics, we really use the PICO framework to characterize the decision problem and really set the scene for a health economic evaluation. And it's really important that a lot of time is spent in refining this framework before kind of beginning any kind of modeling exercise. And it's also, you know, recommended by health technology assessment bodies such as NICE when it comes to submitting evidence for review and possible recommendation for adoption through their guidance. And at Hardian, sort of developed a best practice approach to establish the PICO framework for health economic evaluation. And firstly, this really starts with going through key questions per quadrant of the framework, and we'll go through those in a minute. And we really use this kind of at the beginning of health economics projects to help companies really refine their value story proposition and understand exactly where the value and specifically the economic value of the technology could lie. And it's really important to go to gather the data to inform and develop the PICO in the appropriate ways. For instance, you know, reviewing the clinical and published literature already out there, and also extensive engagement with clinicians and key opinion leaders, particularly in kind of software device digital health space at the minute, where the published evidence is lacking. It's not available yet. So we're currently using relying heavily upon kind of our engagement with clinicians specifically in order to help inform the development of these PICO frameworks for our evaluations. So these are the questions that I just referred to that we recommend that companies go through thoroughly before starting any kind of evaluation. And we use these at the start of a project, as I said, to kind of onboard the company and the technology before we go about beginning to conceptualize any type of model. And so starting with population, now, of course, naturally you need to consider who is eligible for the technology. But then within this eligible population, we need to identify any variation within this population, because the more homogeneous your population is for the economic evaluation, the more accurate and robust your model is likely to be. And also the more likely you are to find the exact data to fit the model also. And once we've identified the variation within the eligible technology population, it's important to then look at how the technology is going to benefit these sub kind of populations in different ways. And once we've done that, identify the subpopulation where the technology is likely to have the most benefit. And then when it comes to the intervention, we really need to consider where the intervention is most appropriately placed within current practice. And this is because the structure of the model, as we'll see when we move on to the modeling slides, is really predicated on care pathways, best clinical practice. And so it's really important for us to understand exactly where the technology sits within that care pathway, to then understand how those care pathways are going to change and how the value of that technology is generated. And for most of the technologies that we're working with at the minute, we are seeing that they have benefit across multiple care settings. And if that is the case, that's obviously fantastic. But with the modeling, we only tend to focus on one care setting at a time, just because if we try to include the benefit of a technology in outpatients, inpatients, primary care, for instance, the model can become incredibly complex and confusing. And the key with health economic modeling really is to keep things as simple as possible, so that your payers and audience can understand what it is that you've done, and what you're trying to show them, in order for them to kind of trust the results that these models are giving to them. And also importantly, it's great to consider who the intervention is going to be placed within the care system, and the type of information that the technology will be giving to individual healthcare professionals. And then in terms of the comparator, typically this is the comparator kind of scenario for most technologies at the minute is standard of care, just because no AI technology yet has kind of formally been procured, at least in the UK anyway. So more often than not, we are just comparing to standard of care. But it is also important to consider competitive products and look at the data available on those competitive products. And as the industry grows, and there are multiple companies competing in the same space, we will need to start factoring in the impact of competitors on the health economic value story. And then finally, coming to outcomes. Now, this is the kind of quadrant of the framework that we spend the most time on at the start of a project. And obviously a technology can have a range of benefits and outcomes, but they won't necessarily all be relevant for the health economic value story. And NICE recommend that you kind of generate a list of 5 to 9 outcomes when it comes to looking at the benefits of a technology. But when it comes to health economic modeling, it really, we recommend that you focus on 2 to 3 of those outcomes for the primary focus of the modeling, just because a simple value story or communicating a few outcomes kind of makes for a simple value story, which then makes kind of communicating the overall value of the product much easier when it comes to conversations with hospitals, trusts, ICSs, or whoever it is you're speaking to when it comes to those reimbursement and procurement discussions. So once we've understood the PICO and the kind of decision problem, it's then kind of sort of time to consider which type of modeling approach is best to take. And the kind of first and most kind of simplistic option is the budget impact model. And as I said, yeah, it's the most simplistic form of economic evaluation that we do. And we sort of synthesize all available knowledge to estimate the likely financial impact of adopting a new intervention in a healthcare service. And we typically look at this financial impact over a period of 1 to 5 years, which is a much shorter time horizon than in other economic models, where you may look at the impact of an intervention over patients' entire lifetime, for instance. And this 1 to 5 year time horizon with the budget impact model really also aligns with how kind of financial decisions and procurement decisions are made, which sort of leads me on to the primary use of the budget impact model. And that really is to obviously not only demonstrate cost savings, but to support you in your sales discussions with budget holders and potential payers. And because the budget impact model is a simpler model, it can be converted into a sales tool that you can actually use in live format during your sales conversations, where you can change the input parameters to generate bespoke calculations for that budget holder there and then during the conversation.
I think the thing to note here is that a lot of the customers that you're going to be talking to are potentially payers, commissioners, who are more locally orientated, who want to have their local data put into the model. These budget impact models are more appropriate for that localization kind of approach, to get bespoke outputs for that region that your customer is representing. Also worth noting that these commissioners and payers are often in place for about 2 or 3 years, and then they move around. So the budget impact model having a relatively short time horizon and a relatively kind of financial focus means that you're going to be kind of producing outputs that's more relevant to them. They want to see changes within the time span of them working within that position, rather than investing a lot of costs in the short term that someone else is going to reap the benefits of. So typically we say that the budget impact model it's around 1 to 5 years, typically around up to about 3 years is when people are interested in seeing outputs and results and savings. I think we have a question in the chat actually. So what is the average time frame and cost to generate one of these models for your products? I think we can probably talk about that a bit later, because to be honest, when it comes to the cost of these models and the amount of time it takes, it all depends on how complex the care pathway is, how many interventions want to include in your model, the amount of comparators, the degree of KOL feedback you want to engage with. So they can take anywhere between 6 months to 1 year to build. I mean, we can build more rapid cost calculators for more kind of sales orientated conversations. They can be built within about 2 to 3 months, but they're not necessarily for public dissemination or publication, as it were. The kind of budget impact models or cost effective models that take between 6 to 12 months, they require quite deep evidence reviews, which we're going to go through later, the whole process of how we go about building these models. And yeah, there is a step-by-step process that needs to be adhered to if we want to go for a publication. So it's it's dependent on the scale of the projects, to be honest.
So yeah, in terms of the types of costs and outcomes that are typically assessed in budget impact models, as per ISPOR guidance, they recommend the inclusion of direct medical costs only. But in theory, you could include anything in a budget impact model that you can put a financial value to, essentially. But as I said, ISPOR recommend the inclusion of direct medical costs only. So, medical costs that come about that are related to the condition of patients, and how the introduction of the new intervention then changes patients' symptoms, disease duration, disease outcomes, disease progression rates, and therefore the change in medical costs associated with that. And they don't typically recommend to include things like indirect costs, such as productivity. However, in some cases, it is appropriate to do so. And we're seeing that actually, with most of the software devices and digital health technologies that we're working with at the minute, that the ISPOR guidance for the inclusion of the direct medical costs isn't necessarily appropriate, because the benefit of these technologies are more around the indirect impacts and the systemic benefits to a healthcare system. For instance, improvements in clinical workflow and putting a monetary value to time savings, for instance, reduction in litigation claims and costs. And then also the problem of multiple patient conditions, and how these technologies can actually tackle multiple diseases at once, and trying to account for that in terms of outcome and assessing the value is something that's quite new to health economists and HER as a discipline. And so this is where we feel at the minute that the ISPOR guidance in terms of best practice evaluation really is lacking, and not necessarily addressing digital health technologies. I'll just quickly go over this because it's not that relevant for kind of where the industry is at the moment. But when you're conducting a budget impact model, it really is important to account for market shares, because naturally when you introduce a new intervention, the dynamic of that market is going to change. And there are 3 potential changes. So if the new intervention is replacing one or more current interventions, that would be kind of a substitution effect. If it's going to be added to the current intervention mix, it'd be a combination. And then the intervention may also have an expansive effect, where maybe it's addressing a patient population that is non-responsive to current to the available interventions, and therefore you're kind of expanding the market as a result, because you're addressing the need of those patients. And it's important to characterize the new intervention in these 3 categories, because they all have different impacts in terms of the budget impact of that intervention. However, as we've said already, we're not quite at the stage yet where we need to be accounting for kind of uptake rates per kind of competitor product, because as you know, not as of yet, we to see kind of a formal kind of procurement of these technologies, at least within the UK anyway. A key part of the budget impact model also is the patient funnel, refining the population, calculating the population for the model time horizon. And this really should be directly linked to the population quadrant of the PICO framework. And obviously the size of the population is going to have an implication on the budget impact or saving of the technology. So a larger population size is going to generate a bigger budget impact, which really kind of goes back to the point of when you are deciding on the eligible population and then identifying variation within that eligible population. The choice of the kind of subpopulation, I mean, almost realistic kind of best practice, and ultimately needs to be the largest population within those variations to kind of maximize the budget impact and savings that the technology could potentially demonstrate. So this sort of brings everything together that we discussed in terms of how the mechanism of the model works. So you begin with the left-hand side box, which is the kind of comparator scenario. So typically this is standard of care. So you take the current healthcare service provision and you refine your total population down to the target population, which really, I mean, the green box is total population, sick population, target population. This really is the patient funnel element of the budget impact model. And once you have that target population, you need to figure out exactly what resource uses this target population are absorbing, how are they treated, how they're being diagnosed in terms of hospital admissions, appointments, treatments. And once you understand this resource utilization, you can then put a cost to these individual resources and derive the cost of illness. We then do this again. Only this time we assume that the new intervention is available to that target population. We generate a cost of illness to represent that scenario, and then the budget impact simply is the difference between the cost of illness, the current healthcare service provision, and the cost of illness associated with the new proposed provision of care that includes the new intervention. And as I've said now quite a few times, the budget impact modeling methods that are set up for best practice are really for traditional kind of therapeutics. But we're seeing the kind of emergence of a new kind of budget impact modeling approach that we feel is optimally going to assess digital health technologies. And these are some of the differences that we are noticing in terms of the modeling, key model aspects. So the population, we are noticing that for the diagnostic support and more diagnostic and AI kind of devices, the populations tend to be more heterogeneous. The decision trees that inform the resource utilization and care pathway mapping are much more complex than they are for therapeutics. The level of evidence that's available to support them is not as developed. And as already covered, the types of outcomes that should be considered within the budget impact models are also different too, in that there's more of an indirect focus on patient outcomes, more systemic benefits, versus the therapeutics where they are directly impacting things like survival and patient condition. And as we've already said, one of the key elements of the budget impact model, the most useful practical use of them, is that they can be used in sales conversations. And they also have the capability to have a kind of a dynamic reporting feature built off the back of them. So if you are, for instance, in a room with a payer, you're discussing your product, you can adjust the size of the model population to their hospital population, for instance, their disease prevalence rates, their costs, composition of their workforce, and the budget impact model has generated a result specific to that hospital. It can then build in this dynamic reporting function that will then essentially populate a report with these results, which you can then share with whoever you've spoken to in that meeting. That then empowers them to, go back into their community and communicate the likely potential or the value of your technology to their boss and their boss's boss, etc. So this really kind of empowers stakeholders and strengthens kind of Salesforce efforts when it comes to securing adoption. So that's the budget impact modeling. Now we can move on to the cost effectiveness analysis, which is the other kind of most common health economic evaluation that we conduct, and you'll see kind of in the published literature also. And the cost effectiveness analysis is the most comprehensive form of analysis. And similarly with the budget impact model, we are considering the financial aspects associated with adopting a new technology. But in the cost effectiveness, we are also then trying to account for the level of clinical benefits and improvement in clinical outcomes that are also being brought about by the introduction of the new technology. And typically these analyses have a longer time horizon also. Normally patient lifetime is typically the time horizon taken. And that's really because then you can assess outcomes like survival. And these forms of analysis aren't typically used for things like sales conversations as per the budget impact model. They're really generally only built for academic purpose or when it comes to technology assessment review processes, such as submitting to NICE for their review and potential recommendation for adoption in the NHS. And in terms of how we quantify a level of health or clinical outcomes in the cost effectiveness, can be done with a kind of a range of measures, life years, disability adjusted life years, but the key one, and I'm sure you've probably seen it floating around, are kind of quality adjusted life years. And this is a utility measure that tries to capture the quality of a patient's life, but also the amount of time that a patient has lived with that specified quality of life. And so one QALY is equal to 1 year lived in perfect health, and then 0 is equivalent to death. And when we use QALYs in cost-effective analysis, this kind of converts the is kind of technically called a cost utility analysis. So you'll see kind of cost effectiveness analysis and cost utility used kind of interchangeably in the literature. But yeah, cost utility analysis essentially is just a cost effectiveness, but using QALYs to measure the level of health. Now, there are two model structures that you can adopt in order to conduct the cost effectiveness analysis, or two common ones. And the first is a decision tree. Decision tree is not specific for kind of health economics. It's used across multiple disciplines, decision sciences. And really you follow a cohort of patients starting from the left of the diagram through to the right. To start with the decision node, which could be, for instance, is the patient population screened, yes or no, or in the case of evaluating a software device, does the patient population have access to said software device, yes or no? And then you follow the patients throughout the tree, and their movement is determined by chance nodes. So probabilities of certain health events happening until they arrive at a terminal or end node. And at this point, it's possible then to assess cost outcomes and clinical outcomes, which can be then aggregated to analyze the results of the cost effectiveness analysis. And decision trees are beneficial in that they provide a nice kind of visual aid for us to assess the decision problem, the question. But they're most appropriate for the short-term diagnostic screening, the decision problems, and really are not that useful when it comes to assessing the recurrence of events, because if we have events happening multiple times, the kind of number of branches that we have kind of expands and gets a bit crazy and a bit of an eyesore and hard to follow. So that really is the main downfall when it comes to decision trees and using them as the kind of key structure for cost effectiveness analysis. But the Markov modeling approach is the kind of most second common modeling approach for the cost effectiveness analysis. And this really overcomes the main benefit of this approach is that it overcomes the limitation of the decision tree in terms of not being able to handle the reoccurrence of events. And with the Markov model, you kind of preset these health states which reflect the disease characteristics or therapy area of focus. And on the screen there, I've got a very simple example. So patients are either sick, healthy, or dead. And typically, you start patients in the same health state at the start of the model time horizon. So for instance, all patients in this case could start healthy. And then the time horizon of the model is broken into increments. So say you've got a time horizon of 50 years, and that time horizon can be broken into yearly increments. So if the time horizon is 50 years, you'll have then 50 cycles of the model, each cycle equal to 1 year. So cycle 0, all patients will be healthy. And then in cycle 1, you'll have some patients that may die, some patients may remain in their healthy state, some patients will get sick. And then cycle 2, again, some more patients will die, some patients that were previously sick may recover and become healthy again. And you continually follow patients in these cycles until you've reached the nth cycle, or the 50th cycle, for instance. And then once you have done that, it's then possible to calculate the expected level of cost and level of clinical outcome per cycle. And the kind of movements between these health states are really determined by the transition probabilities, and they really dictate the rate at which patients move across these health states. The main kind of problem with the Markov modeling is something called the Markovian assumption, and that really pertains to the issue that these individual health states are mutually exclusive. So the fact that a patient has been in a cycle previous, in a health state in a previous cycle, will not determine the rate at which, or the chances that they'll move to a different cycle, a different state in the next cycle. And this can be kind of too restrictive and problematic with certain disease and therapy areas.
Essentially, what we have to do is lump all patients together already. We cannot account for patient history when they're modeled in this kind of Markovian way. If patient history and the experience of the patient previous to the cycle they're in is important, we'd have to go with a really complex model called a patient level simulation, where we start modeling individual patients and how they run through systems. And those kind of event simulations are incredibly data heavy. As you can imagine, we need a lot of data to inform the distributions around the patient parameters. So that's a level of detail we perhaps won't get into in this session. And hopefully, I think for digital health technologies, perhaps it's a level of sophistication of modeling that isn't needed. Although it is always better to have more granular results. The data requirements are still, even for the pharmaceutical industry, are very hard. So yeah, I think the Markov approach is probably the most sophisticated type of modeling that we will see for any kind of HTA submissions.
Yeah, we've kind of already touched upon transition probabilities. But as I said, yeah, they really define how patients move across these different health states in the model, and are typically derived from natural disease history data and randomized controlled trials that give you the kind of impact that the technology can have on the rate at which patients move between health states across the model time horizon. And another kind of constraint with the Markov model and transition probabilities is that I tend to assume that they are held at constant over time. And again, this may be too restrictive. And so when that happens, it's possible to turn to patient level simulations, as Tushar just explained, but it's also another way to kind of get around this is to also conduct survival or time to event analysis, where the focus really is to focus on the benefit of the intervention really is to improve the time or impact the time to a specific outcome versus the outcome itself. And typically these analyses leverage patient level data, so data that's collected in randomized controlled trials, which allows us to derive more precise estimations versus the kind of cost effectiveness analysis or budget impact modeling approaches where we're treating patients as one big cohort rather than individuals. And in a time to event or survival analysis, we use the Kaplan-Meier estimator to derive the probability that a patient has experienced a certain event at a specific point in time. And with this estimator, this also allows us to derive a curve. And with this curve, it's possible to then extrapolate beyond kind of clinical study time periods, which is obviously beneficial when it comes to predicting the impact of a technology way kind of into the future, for instance, with the 50-year time horizon.
Yeah, so this type of survival analysis is typically seen in oncology, where we have overall survival, progression-free survival, and death as the typical health states, and these survival curves dictate how patients transition from a progression-free survival state to an overall survival state, and then there's a background mortality that's applied as well. So yeah, as Lisa mentioned, we use these curves, we then extrapolate, we do some interpolation to fill in the gaps in between the data points we have, but also some extrapolation, and a lot of extrapolation, because sometimes we have 12-week trials, and up to 12-month trials, and we need to simulate basically the rest of the patient's lifetime, so the next 20 to 30, sometimes 50 years. So we do have to do a lot of work on the extrapolations, validation of the extrapolations from both a clinical and health economic and statistical perspective. So looking at Bayesian information criterions, and then going to clinicians and showing them the curves and saying, does this look reasonable? Does the plateauing of this curve look reasonable at this time point? And feeding that back into the economic model. But just coming back to the chat now, so we've got a couple more questions. I think we talked a bit about the transition probabilities, but just coming back to the patient level Markov model, as I mentioned before, it's incredibly complex, and you wouldn't necessarily perform those patient level simulations in Excel, because essentially what you're doing is simulating individual patients, developing distributions around each parameter for that patient, sampling from that patient, doing these kind of 10,000 to 100,000 simulations of patients, running through the models, and doing that in Excel is incredibly burdensome. So we end up doing that in Python or in R. The problem is that the clients, the people that you're making this argument for, the likes of NICE potentially, or other HTA bodies, they're not necessarily capable of reviewing that code and understanding that code. So that slows down the whole process massively. So there is value in building a more complex model, absolutely, but there is even more value in communicating it and making sure your HT body understands the value messages, the economic value story in the most simple way possible, because it just slows down the whole process when there's a whole lot of code for them to review. Whereas with Markov models, yes, they're incredibly simple because you're avoiding all the aspects of the patient history when you're modeling a cohort and lumping them into health states. But that simple mathematical framework is so easy for them to understand and so accepted that it doesn't look like, for example, you're trying to game the system by overcomplicating things and hiding things in complexity. So that might not necessarily be the case for digital health technologies. There's perhaps, from what we see, a little bit more trust from HTA bodies like NICE on the evidence packages being submitted to them. But when it comes to the pharmaceutical industry, there's always an element of distrust of these super complex models being submitted. Is there a reason why it's super complex? Is this the only way you communicate economic value, is with this really complex model that nobody understands? In which case that lack of transparency is perhaps damaging to that relationship between the HTA body and the company submitting. So it's always better to try and go with the most basic model possible. If you can submit a budget impact model and that communicates your economic value story, that is the way you should be going. If you do improve quality of life and length of life, yes, by all means consider cost effectiveness modeling, but that is more data, more work to review, bigger budgets required to develop those kind of models, bigger timeframes for both the vendor to produce that, but also the HTA body to review that as well. So these are the kind of balancing equations we need to make when we talk with our digital health companies that we're talking to. Is the additional budget and time and complexity worthwhile? Can you not just get away with a budget impact model? And I think Lucy will attest to that. NICE is becoming incredibly amenable to simple budget impact models for digital health technologies.
So I'm aware that sort of gone on for about an hour now. So I think it'd be good to take a quick 5-minute break, and then reconvene in 5 minutes, where we will kind of finish off going through kind of more lecture part of the workshop, where we'll focus on interpreting the results of these models, and then we will move into a more kind of worked example, to hopefully demonstrate some of the things that we've been talking about.
Thanks, Lucy. Shall we make that 10:05 return time? Yeah.
Great.
Great.
And feel free to submit any questions in the chat during that 5 minutes as well. We can address any when we return.
Okay, so as I said, now we have gone through kind of two key types of evaluations that we do. We can then look at what we do in terms of, once we've got these evaluations, what do we do with the results, account for things like uncertainty, and the types of evaluations that we can pivot to when data is missing also. So the cost effectiveness analysis, you use aggregations of the cost outcomes and clinical outcomes to generate something we call an incremental cost effectiveness ratio, or an ICER, which is essentially is a ratio of the differences in the cost of the two interventions, the differences of the cost of the two interventions over the difference in effectiveness of the interventions. And policymakers and decision makers use the ICER to determine or establish whether they should recommend technology for adoption or not. And typically, with pharmaceutical interventions, it is the case that the questions of intervention A is more costly, but more effective. And so this is really where the ICER and ICER thresholds become useful, because it allows the decision maker to really decide, at which point the technology doesn't become good value for money. Now, with digital health technologies, NICE kind of expect most interventions to be less costly than standard care, but more effective. So the kind of use of an ICER is kind of less justified, almost, because we're not having to evidence or demonstrate why we should be spending additional money for that additional effect. But nonetheless, it's still important to be aware of these ICERs and their use in terms of decision making and the reimbursement process for interventions. And in the UK, when NICE don't publicly say that they have a threshold, but analysts have done kind of assessments of all NICE submissions and worked out that NICE do have a threshold at which they recommend technologies for adoption and which they don't. And that threshold for most interventions is between £20,000 and £30,000. So they won't recommend technologies for adoption if that technology is generating an additional quality adjusted life year for more than £20,000 to £30,000. And for end of life treatments, this is adjusted upwards. but for the majority of interventions, the threshold it tends to be 20 to £30,000. Now, this is specific to the technology appraisals that NICE do, and when it comes to NICE process and submissions to NICE, they have a range of programs with which they evaluate technological interventions through, and the technology appraisals is the biggest one, and that's the one that all the drugs, pharmaceutical interventions go through. But the programs for evaluation that are going to be more appropriate for software devices and digital health interventions will be the diagnostic assessment programs, or the MedTech program. And of course, we've not really seen, well, no AI technology anyway yet has had a formal recommendation from NICE. So we are not yet sure in terms of what the thresholds for technologies is going to look like yet. But yeah.
Yeah, just to add to that, so you might be wondering, £20,000 per QALY, £30,000 per QALY, that's quite a big confidence interval for decision making. And how that works is, if there is a lot of trust in your data package, for example, you have a multi-year RCT that proves the data that goes into the economic model is valid for the UK, for example, so there's a lot of trust in your model, then they're going to be more generous with the threshold. So that'll be around £30,000 per QALY. If you've had to synthesize data points from multiple other sources, if you've had to go to KOLs to generate assumptions that go into your model, so there's a lot less data, or your trials or your pilot studies are run in a different country, for example, they're going to be a bit more strict on that threshold. So the threshold for passing a cost effectiveness assessment by NICE is dependent in part on the uncertainty around the model, and that is all driven by the data points used in the model. And just to touch upon another point as well, we're saying that cost effectiveness modeling perhaps isn't so relevant for digital health technologies because you're expected to be cheaper and as effective as standard of care. But at the moment, standard of care doesn't include any of your digital health technology competition. So as the markets become more and more saturated, it's going to be harder to make those kind of budget impact assumptions, and you're actually going to have to make more cost effective assumption. So you might be more effective and more costly than a competitor in the market if you're maybe second or third to market. So if that's your economic value story that you're going to be telling, that there is a competitor in your market and they were there before you, then you might actually need to go with a cost effectiveness story, because you might be more effective and more costly than that comparator. But if you are first to market and standard of care is current practice, as we see in the UK at the moment, then yeah, cost effectiveness modeling perhaps is a bit excessive for the moment.
So with health economic modeling, we are essentially creating a simulation of reality, on what happens on the ground in practice. But obviously we can't account for everything. And so they tend to be, so the models are a simplistic kind of representation of what happens in reality. And as a result of that, there's always going to be some degree of uncertainty present in a model. And the sources of this, for one, can be analyst time, resource, and constraints. You know, a model's never going to be perfect. It's always tempting to kind of just keep bashing away at things, add in this, take out this, trial and error, different bits, but ultimately have to draw a line somewhere. And then also there is if there's any lack of evidence or data to publish a model for certain parameters or inputs, the choice of methodological approach, inclusion of parameters, model structure, the assumptions made around population, disease progression, and then there's also an element of stochastic uncertainty, random variability 2. And there are kind of 3 ways in which we account for uncertainty in models. The first way is the deterministic sensitivity analysis. And this is kind of the most simple way to account for uncertainty, where you take parameters, or ones that you are uncertain of at least, and you change the input value from base case to an extreme or a plus minus value from the base case. It can be, for instance, 95% confidence interval, and you assess the impact on results. For example, your incremental cost effectiveness ratio as a result of that. And you typically present these in the form of a tornado diagram, as you can see here on the right. So you can kind of graphically and visually assess which parameters your model is most sensitive to. And then it's also possible to conduct a multi-way sensitivity analysis where you vary more than one parameter input at a time, because typically with the one-way sensitivity, you vary one input at a time, keeping everything else constant. This is more kind of akin to a scenario analysis, which we will get onto in a minute. The second approach we take for accounting for uncertainty is the probabilistic sensitivity analysis. And this is where you vary multiple parameters at any kind of given point in time. And you don't choose the change in the inputs per parameter are not constricted to like one or two extremes. They're extracted from a distribution that you assign to that parameter before you conduct the analysis. And essentially what you do is you run the model a certain number of times, typically 1,000, in what we call a Monte Carlo simulation. And for each run, you then derive an incremental cost effectiveness ratio, and can derive things like mean incremental costs and mean incremental effects, and kind of account for uncertainty through those also. And then finally, with scenario analysis, this is the final way we account for uncertainty. And this really is to it's more the focus moves away from addressing parameter uncertainty, is more around model structures. And this is very like user driven. So you as a company might want to perform some scenario analysis where you vary price, size of your population, for instance, to assess like almost like a worst case scenario. And then vendors or consultancies also conduct scenario analysis to test assumptions, and also perform kind of quality checks on the model. But then also health technology assessment bodies such as NICE will also request scenario analysis where you may be forced to kind of present your worst case in terms of the benefits and likely costs associated with your technology. And I think a good example really is, as we were going back, as we were saying earlier with the budget impact modeling, it's possible to change the inputs of the model to generate bespoke calculations for a particular hospital or payer, for instance. And this is kind of an example of a scenario analysis. So we've talked through the different types of models, results of these models and how they can be used. But just to kind of summarize all of that, this is the process that we follow in terms of for best practice when it comes to developing the health economic evaluations. So we always at the start of a project, we always start with an evidence review. Ideally, it should be a systematic literature review of all available health and clinical evidence, health economic and clinical literature. But this is not always realistic. I mean, the budgets and time that are required to do systematic literature reviews are big. I mean, systematic literature reviews can take 6 months as an exercise on their own before you've begun any form of modelling. But when it's not realistic or possible to do systematic literature review, it's still important to review literature, but in a systematic way. So, you know, at Hardian, we kind of conduct what we call targeted literature reviews, where we identify kind of a small selection of key literature, still using search strings and the relevant search engines like you would do in a systematic literature review, only we're not covering all the literature as per kind of a systematic approach. And once you've done that, move on to the conceptualization phase of the evaluation. Step one to that is the decision problem, and that really goes back to the PICO development framework that we were talking about earlier. And then step two of that is the analytical model itself. So that's the choice of the model structure, whether it's going to be a decision tree, a Markov model, patient level simulation, and using findings from the clinical and economic literature review to characterize that framework, which really should be reflective of the economic decision problem, but also clinical practice, not only kind of best clinical practice, but also potential variations in clinical practice also. And then we move on to the data gathering phase, which really involves then testing your conceptual model with clinical key opinion leaders, policymakers, to test that you have, for one, understood the potential that the technology can have, and two, that the assumptions that you are making and the choices that you're making for the assumptions of your models are accurate and going to be clinically robust. And then you also then need to source the data to populate the conceptual framework of the model, which, as we will kind of get onto in a minute, is, I think, the biggest challenge for the evaluation of digital health technologies and software devices currently. We're finding that, the data that's required to do formal health economic analysis is currently lacking. But there are ways around that, as we will get onto shortly. And then once you've gathered all the data, you've got your conceptual model, you can then begin to actually draft the model and make it happen. And we use a range of modeling softwares for that, most commonly Microsoft Excel, but then also programs like R Stata and also Triage too. And then, once you've constructed your model, you can then kind of go about the fun bit, which is deriving results, conducting these uncertainty and scenario analysis, and then after that, then also testing these results with clinical stakeholders and key opinion leaders before kind of finally closing off the model, and also submitting or writing up your methods and results in a manuscript, which you can then submit for peer review, which kind of gives your evaluation that kind of final polish and shine. So we often get asked at the start of projects by companies, what type of data should we be, what type of data do we need in order to conduct an economic evaluation? And we've managed to group them into kind of three categories. And the first one is the data around the technology. So for diagnostic support devices, which is the majority of the companies that we deal with at the minute. Data on your confusion matrix, sensitivity, specificity, any outputs or information on the presence of disease, and then also the variation in the effect or efficacy of the technology across different healthcare professionals. So for instance, it could be the added benefit of the technology when equipped with a radiologist versus a nurse practitioner, for example. And then also we need to have data on the costs, implementation, maintenance, training of the technology, and also any adverse events related to the technology. And then that typically is more focused towards therapeutics versus diagnostics, because the kind of adverse events or negative consequences associated with the diagnostic technology can be accounted for within the confusion matrix. And then the clinical implications and workflow implications really are the data on the outcomes, and the clinical implications or outcomes data is really where we're seeing the gaps in the data for models at the minute. And so if you are considering doing a health economic evaluation, really would encourage you to think about what data you have in terms of the clinical outcomes of your technology. And then the more workflow systemic benefits tend to be, as we said, a direct benefit of software devices. But these can also then be linked back to clinical outcomes in a more direct, indirect manner. For instance, if you are detecting lung nodules sooner, how many more cases of lung cancer are you detecting in stages 1 and 2 versus stages 3 and 4, and the impacts on overall survival and quality of life from that. So if some of the data that we've gone through is missing, or you plan to collect it, but you really are eager to do some economic analysis before then, there are two kind of types of evaluations that we can do anyway without the data. And the first one is early economic modeling. And this really is the one that we recommend companies do versus the second option of a multi-decision criteria analysis. Now, the early economic modeling essentially is just conducting a budget impact model or cost effectiveness analysis, but on a much simpler level. You may have fewer health states, for instance, fewer assumptions. Maybe you would only assess like 1 or 2 outcomes to really understand what's going to be driving your cost savings, and therefore where you should be collecting your data, because investing in data collection is really expensive, it's very time consuming. And so by carrying out these early economic evaluations, you can minimize the risk around collecting this data the kind of risk of, you know, wasting money, I suppose, and really to make sure that you're collecting data on the outcomes that are really going to demonstrate and maximize the value of the technology. And then there is the multi-criteria decision analysis, which is more of a social science qualitative exercise, where you essentially develop a set of criteria to assess the intervention versus a comparator. For instance, you know, one criteria could be intervention efficacy, one could be costs associated with reduction in hospital admissions. You then convene a panel of stakeholders to establish the relative weights of these criteria. So how important is the intervention efficacy, for instance, in the overall economic value or potential value of an intervention. And then you assign scores to each of these criteria for the intervention and the comparator to then generate a final score for the intervention and the comparator. And I guess the real benefit of the MCDA approach really is that you can account for qualitative values, value outcomes, for instance, like staff retention or improved confidence in the workforce, for instance. But they do kind of open up a lot of potential for kind of gaming the system, and potentially, for instance, you know, if you know your technology doesn't perform so well in certain criteria, for instance, reducing hospital admissions, you know, it is possible to game the mechanism slightly and assign a lower weight to the criteria where you know that an intervention doesn't perform as well as its comparator, to then kind of bias the results. Whereas with the early economic modeling, you know, the numbers are dictating the result, and there's less room for gaming and mining in comparison to the MCDA. So if data is missing in terms of the economic evaluations, we would always recommend the early economic modeling approach.
Yeah, I think in summary, the MCDA approach isn't massively adopted for evaluation of health technologies. It's something that NICE has been talking about for the last 10 years or so, but we haven't really seen any NICE submissions using this approach. So it's more for kind of prospective adoption within the client context. So PHE, Public Health England, have used this quite a bit in the past, for example. And care commissioners have used this as well for prioritization frameworks. So you can probably do some searching and see some prioritization frameworks that have been built for MCDA that I've worked on specifically for Public Health England. But yeah, I think Lucy is right. There is an opportunity to game the system here with economic modeling. It's more quantitative in nature. It's, yes, we can game a system with a quantitative model as well. That we're not saying that quantitative models are perfect, but with the weighting of the selection of the criteria, the weighting of the criteria, like Lucy says, you can choose the criteria that performs better for your technology. You can de-weight the ones that you don't perform too well, for example. So it's not necessarily the best and most well adopted one at the moment. It does have its benefits though. I mean, it's a mixed method approach. You can put data into the MCDA and you can use qualitative data as well, which is great. You're also engaging with stakeholders, so you could have the likes of your care commissioners or NICE in the room. You could have patients and patient organisations in the room and care commissioners in the room, and get them to establish the criteria and the weightings behind what they think is a good intervention. And then we go away, do the mathematics around how each one performs, each possible intervention performs, and then they feel more engaged in the process. They have essentially redesigned the evaluation, and it's a lot quicker as well as such. So there are real good benefits of MCDA that have been pushed through the last few years by NICE. It's just not really being readily adopted, unfortunately. We do have a question in the chat around decision curve analysis. So that is something it's been around for a while, actually. I think in the early 2000s, I started coming across decision curve analysis. It's not really been adopted in HEOR, to be honest. I know it's focused on prediction models and diagnostic tests, so it's unsurprising because most digital health technologies are focused on diagnostics, whereas the whole history of HEOR is kind of related more to therapeutics and pharmacological interventions. So it's not surprised that decision curve analysis hasn't really been adopted, but it is something that people have been talking about, and I think perhaps it's going to be one of the things that we need to look into as an alternative option for evaluation moving forward. And then another point from Samir, yeah, the weighting criteria is subjective. Yeah, exactly. I think we absolutely get that. I think and that's the whole idea around potential for gaming the system. But at the same time, by having the stakeholders that making decisions in the room, helping you to establish that criteria and the weight of those criteria, and like you mentioned as well, working with clinical key opinion leaders as well, it works really well to try and get everyone bought in to the same criteria and the same weighting. Now, there are other forms of bias that could be introduced. It's not just about the weights and the criteria. It's about the actual. It's about getting patients and KOLs involved as well. There is essentially a bias for them to promote a new intervention. Obviously, patients want access to more substitutes in a market so that they have a variety of choice. They can cycle through multiple products. So there is going to be an inherent bias towards a new intervention in an MCDA, whereas maybe NICE could be biased too. If they're in the room, they could be worried about financial constraints and be focused there and focus their weighting on financial concerns. But I mean, those are relevant concerns, but they're like we've been saying, it's about controlling of that bias and making sure everybody agrees, perhaps by running Delphi panels as well, that that we have been able to minimize bias, and getting KOLs involved with the process, I think is really important, as suggested. Yeah.
Okay, so just to finish off the kind of lecture part of the workshop, I'm just going to talk a bit about the NICE evidence standards framework. As I'm sure you're familiar with, the evidence standards frameworks really have been set out by NICE as the guidance for evidence generation to not only support companies when setting out on their evidence generation to support the value and kind of adoption of the technology, but also for budget holders and decision makers to help them with identifying the types of evidence they should be looking for when making decisions whether to reimburse these technologies or not. And standards 17 and 18 are relevant for the health economic evidence generation. But essentially, the overall takeaway from the framework in terms of health economics is that, at the very least, a budget impact analysis should be conducted. And in the cases where a digital health technology is considered to be higher financial risk, a cost-effectiveness analysis should also be carried out. And it's slightly, we've spoken to NICE about what they mean by kind of high financial risk, and beyond identifying the factors that may contribute to a technology being higher financial risk, they don't really have a clear definition of or kind of profile of what that higher financial risk could look like exactly. But things like the extent of commission coverage, so if you are aiming for national adoption or large-scale rollout, the level of changes to current care pathways that are required, and also implementation costs. And that really is because kind of going back to why we would conduct a cost effectiveness analysis in the first place, and why the incremental cost effectiveness ratio is used by decision makers, and that it really is most appropriate for those interventions that are going to be more costly than the comparators, but also more effective. And so that's why they are recommending that technologies that are going to be higher financial risk, i.e. likely to be more costly than the comparator, those are the interventions that are going to be requiring cost effectiveness analysis. But other than that, a budget impact model will be sufficient. But just on that also, now, as I've said, NICE have very different programs for assessing interventions, and for the technology appraisals that all the pharmaceutical interventions go through, a budget impact model and a cost effectiveness analysis is typically required for all products. And NICE have publicly said that they recognize that there is a gap in the level of evidence requirements for digital health technologies versus pharmaceuticals, but they really are kind of pushing or vision these differences, or the requirements, the level of requirements to converge. So we do expect that, although for now, for the majority of interventions, a budget impact model is sufficient, we do expect it to move towards a budget impact model plus cost effectiveness for all digital health technologies, as it is currently set out for pharmaceutical interventions. So yeah, now we're just going to go through one of our current projects. We'll go through the methods and some of the challenges that we're facing in this project, which kind of is reflective of a lot of the projects that we do at the minute. We haven't got any kind of screenshots or pictures of a model, of the model itself, or any results. However, the results of this analysis will be published in a journal in the next 6 months or so, hopefully. So for those of you interested, can look at the final results when we get to that. So yeah, the technology intervention of focus is an AI tool to support the detection of fractures on X-rays. Now, the client came to us with information that allowed us to populate a PICO framework that was more reflective of the technology effectiveness, kind of in a wider sense. The tool kind of has CE mark to operate on adults and pediatric scans, all fractures below the neck. Identified comparator is going to be standard of care, and the outcomes or the benefits that the client thought the technology has are listed below. Efficient referrals to fracture clinics, reduction in litigation, reduced supervision of junior staff, impacts on hot reporting abilities, reduction in patient recalls, and also decreased reading times of X-rays, specifically in the emergency department. Now, the client came to us wanting to focus on the value of the technology placed in accident and emergency departments across the NHS. And that goes, the reason for them choosing that really goes back to choosing the care setting where the majority of fracture patients are seen, therefore kind of maximizing the budget impact or economic impact of the technology in terms of economic modelling and analysis. And so we essentially took this PICO framework, spoke to our internal clinical team, conducted some evidence review, and also tested this framework with key opinion leaders or clinical experts to get their feedback on where they thought the technology is going to be best placed and generate the most likely value. Move on to the next slide. And part of that, we got them to rank the outcomes in terms of clinical need or importance. And the outcomes that came out on top were the reduction in patient recalls, efficient referrals to virtual and traditional fracture clinics, and the reduction in litigation. And it was really interesting to find out kind of what they thought about the three that weren't ranked the highest. And so, for instance, with the reduction in supervision of junior clinicians, a couple of the A&E consultants said that actually it's not a bad thing to supervise junior clinicians, because without supervising them, you know, how you're gonna ever train them and help them improve. And for that reason, they kind of ranked that a lot lower. Increase in hot report abilities. Some of the clinicians that we spoke to hadn't necessarily heard of hot reporting. So, and for that reason, they ranked it lower. And then the decrease in reading time. This was something that came out on the bottom, and I think this is a great example because from the perspective of a radiology department, the technology was proven to increase reading and reporting, reading and reporting times. But then when placed in the accident emergency department, the same value wasn't necessarily wasn't seen by the KOLs, because they said essentially that when you're looking at an X-ray in a busy A&E department, you're looking at it for like 30 seconds or so, and then deciding and making a decision and moving on. And so the technology is not necessarily the technology they thought is not necessarily it may reduce the time, but not significantly so to demonstrate any kind of economic saving to that department in that care setting. And so we asked them to comment and rank the outcomes that the client had given us, as I've shown here, but we then also asked them to comment on potential additional economic outcomes that we identified in our literature, which were heavily focused around the resource use of those patients given a false negative detection or a false positive detection of a fracture on an X-ray. Because obviously, if someone is given a false negative detection, for instance, are they likely to represent to hospital with a worse condition and therefore require higher treatment than if they had been detected in the first instance? And the KOLs said that yes, this does happen, but the time that you identify, or how quickly you identify these false negatives, really is going to impact the level of additional resource that the false negative patients are going to need. And And things like they identified the avenues in which these false negatives will represent to the healthcare system. So initially we just assumed that all patients will come back to A&E, but then the KOLs also actually said that, I know some of them will go to their GPs, some will be identified through the radiology and A&E review setup that some trusts have. And in terms of the false positives, we did initially think that, from the literature, that maybe it'd be possible that some patients with a false positive may then have access to certain treatments. But then we really used the KOLs to understand how far down care pathways would those patients get. So for instance, with the false positive referral onto a hip fracture pathway, is it likely that someone would end up in surgery only to find that they didn't have a fracture? And obviously, so it's really useful to get the KOL's input on that, because this really allows us to determine the resource utilization associated with each of these populations. And then to kind of on the point of population, the main bit of feedback we had from the KOLs was that looking at trying to capture the value of the technology in all fractures below the neck was just something that they thought was unrealistic because of the variation in care pathways associated with all the possible different fractures that you could identify below the neck. And so as a result of that, we chose to focus on a few, and they kind of all independently identified and recommended that we focused on hip, wrist, and ankle. And so with everything we found in the kind of clinical guidelines, engagement with the KOLs, and our kind of internal clinical team, we then used this to produce the final, the refined PICO that was appropriate and really characterizes the economic decision problem. So the population, we decided to look at adults only, because again, the kind of treatment and management of adults is different to pediatrics. Adult population is bigger than the pediatric. Focusing on NHS emergency departments for those suspected with a hip, wrist, or ankle fracture. And the primary economic outcomes chose to focus on are the efficient referrals to fracture clinics, the reduction in litigation and patient recalls, purely based on the kind of ranking exercise that we performed with the clinicians. And then we identified the kind of unnecessary treatments, second line imaging, amount of specialist time spent with specialist time kind of absorbed by false positive patients, but we kind of parked those to be kind of conducted in a kind of secondary kind of future analysis, because as we said, it's better to, especially with the kind of first modeling exercise, to focus on 2 to 3 kind of outcomes where we believe the technology to have the highest impact or value. And so this is the structure of the budget impact model that we then have conceptualized. So we have the starting population, fracture population, a kind of decision node, which is then, is a fracture interpreted or not? And then the chances of that interpretation in the ED being correct or not. And then the resource utilization kind of implications of those true positive, false positives, and false negatives that occur after that. The model time horizon that we've chosen for in this case is going to be 1 year, just due to the kind of lack of data that we have available. But there is kind of a possibility for us to kind of extend that if and when the data does become available. And the biggest challenge that we are having with this at the moment, as you can probably guess, is based on everything we've talked about, is the data that's available. So the data to support the efficacy of the technology in improving, for instance, the false negatives and false positives is the data that is readily available. But then looking at the implications of those false negatives and false positives is where we are coming, kind of hitting a block. And so again, this is really where we see the need in terms of data collection to support the economic evaluation of software devices and digital health technologies, particularly in the radiology space. Okay, so yeah, I've gone on for another hour, so I think it's time for another break. I think maybe we should extend this to 10 minutes. And then after that, we can come back and we'll then have about an hour for any Q&A or discussion as we scheduled for. So, yeah.
Yeah, and in that 10 minutes, take some time to think about, some of the issues you might have had about PICO frameworks and reframing, like we have just displayed. Any of the KOL feedback you might have received for your technologies. It'll be good to hear some discussion on your own experiences. So not just questions, but feel free to share some discussion on how you've been finding things for your own company and technologies.
Okay then, so has anyone got any questions, kind of any experiences they'd like to share so far in terms of generating health economic evidence? Be great to hear from some of you.
I think we might need to warm up the crowd, Lucy. So let me start with asking you a question. So what do you think is the biggest problem being faced by digital health technologies at the moment when it comes to health economics?
I think, as we said, it really is the data availability. And I think the key really is with the data is to start thinking about what data you should be collecting to support the economic value story as early as possible. And really, all economic models are, as you know, Trish, are built off data collected in clinical trials, real-world evidence studies, and therefore, yeah, we really need to be thinking about the types of data that should be collected to support the economic value, kind of in line with the development of clinical studies. And for that, they need to be doing, companies need to be conducting kind of early economic evaluations to determine which of these data points to feed into study designs.
Yeah, exactly. And I think, we've talked a lot about availability of data being key, but at the same time, we don't want people to be waiting to the very end of their data collection to performing their economic modeling. I know we talked a bit about early economic modeling, but what we've done as health economists for the last 20 years with the pharmaceutical industry is to perform early economic modeling, sometimes with zero data. We use things called target product profiles, where you just get people in a room and saying, oh, well, what do you think the efficacy, what is the sensitivity or specificity of the product that you think that we're going to target? what is the standard of care at the moment? So why don't we just at least model the standard of care and then work out, okay, if we think we're going to be 10% better, well, let's model that, understand the economic value of doing that, and understanding, well, what is the threshold for which we make a big budget impact? Do we actually need to move the needle 1% in one direction by 1%, or is it actually 10% is actually going to get traction in the industry? So whilst we do talk about data availability being really key and a problem for digital health technologies, that is only a problem when you come to us at the end of your kind of data collection activities and you present your data, and then we try to fit it into a model and it just doesn't work. I think ideally you do your economic model whilst you're kind of designing your study protocols, so we can then help shape what data you are collecting to then go into the model perhaps a year later.
Got a question in the chat. ICSs and hospital trusts are not equal in their clinical financial capacities, capabilities, and possibly care pathways. What factors should be considered when selecting sites for data gathering? I think
Yeah, this is
you answer this better than I can.
Yeah, this is a really good question, because it's one thing gaining traction via data collected in one site, but if that site isn't representative of the UK, for example, then the data being collected is going to be questioned. For example, I remember when I was performing my PhD at Moorfields Eye Hospital, which was great, gold standard for service provision in the UK, built an economic model specifically for glaucoma and was well received. But then when it went out to the real world, everybody looked at the care pathways and said, yeah, we're not doing that. This economic model is totally non-reflective of what we do in real world clinical practice. The financial capability of Moorfields and the capacity to provide those services which was being modeled was not available in the rest of the country. So the key is, yes, identifying multiple centers with a wide range of capabilities so that we understand the pathway from the different scales in terms of capacity and capability and financial capability as well. And that we're modeling all of those kind of eventualities. But the models that we build, especially for more specifically for the budget impact models, are designed to be incredibly flexible so that we can adapt the model to reflect multiple pathways. So if you're going to different care commissioners or ICSs and they have a slightly different care pathway, then it's actually quite easy to, on the fly, edit the decision tree. You can turn off parts of the arms of the decision tree and the branches. And that is really key. So when we design and build our models, they don't look like spreadsheets. They have to look like software that looks like something that you might see as an application rather than a spreadsheet, so that people feel comfortable with playing with the models. And a lot of the work that we've done historically with the pharmaceutical industry is not just on building tools for HTA submissions for the likes of NICE, it's actually building tools that go to sales reps and training sales reps on how to tell the story of the economic value that the technology provides, and all the kind of challenges that you might face when telling that story, and building out things like objection handlers, running gamification sessions between key account managers and regions so they can compete against each other because they love that kind of aspect of competition, but essentially training them on facing all the questions that they're going to face, and being as skilled with the tools that we give them. But ultimately it's down to how flexible the tool is that we give you. And within the Excel framework, you guys are probably used to seeing quite boring plain spreadsheets, but the tools that we build are more like applications that you'd see on the Google or App Stores, for example. And I think maybe just to add to that as well, actually, I think Lucy could talk a bit about how important KOL feedback is. We've had projects where we have been provided with PICO frameworks that has been set in stone by the company, and they come to us, and actually we go to KOLs and test those PICO frameworks, and it absolutely changes, fundamentally changes. So I think that is I think Lucy, you could probably talk a bit about that as well, how important it is to get KOL feedback during the PICO phase, right? We've had some projects where we've had to really spin the PICO framework in order to make it relevant for the region of interest.
Yeah, and I think also developing a PICO framework per market. The specification of a PICO for an economic model in the UK for the same problem will completely differ, tend to, between, let's say, the UK and Germany, for example, or Australia, or the US. Particularly, I think the best example is with radiology products. You know, in the UK, there is value in the radiology products preventing second-line imaging, or the need for second-line imaging. But if you go to the US, that value proposition completely dissolves, because in the US, hospitals earn more money from doing more scans. So yeah, accounting for those variations and considering those, not only, you know, within the healthcare systems, across variation across different localities within a specific healthcare system, but the variation and change in the benefit technology across different markets also.
Yeah, and I think coming back to the capabilities discussion as well, I think it's up to us to provide evidence that the audience can receive. I've mentioned before the kind of benefits of moving towards a budget impact model versus a cost effectiveness model, because it's easier to understand, and trying to veer away from those perfect patient level simulations based in R, which are just not going to be absorbable to an ICS or a trust, right? So the key thing is for us to build models that are simple enough to be digested. So Lucy, for example, and the team would receive really complex care pathway diagrams, and we then have to go away and try and simplify that as much as possible, so that even the most basic commissioner would be able to get it. Because whilst, you know, societies produce these amazing care pathways, the comprehension of some of the commissioners and payers who are focusing on multiple therapy areas is just not there. So you have to just make it as simple as possible for them to follow, because like we said before, if the care pathways are too complicated and therefore the model is too complicated, it's just not going to be trusted. But essentially what we try to do is to empower the person receiving the model to be able to tell the story on your behalf. So your client, the payer or the commissioner that you're talking to, needs to be able to become your advocate. Things like dynamic reporting. So you might build an economic model in Excel, or could even be a web-based tool, and you run through all the parameters, all the local numbers about incidence and prevalence and population size and frequency of follow-ups and monitoring visits and all that stuff. But then you're relying on that person to be able to absorb all that information and then communicate it to their senior teams and senior leadership teams. So things like designing the economic models to produce dynamic reports, so that you can, at the click of a button, email that person that you were talking to with a copy of either a copy of the model or a PDF report of all the numbers that you agreed and all the savings and outputs that was agreed. I think is incredibly valuable, and it empowers your clients to be able to speak on your behalf and communicate it to their senior leadership team. So that kind of helps to bridge that capability, the asymmetry and capability that we see with some of our clients.
Any more questions, or any questions? It'd be interesting to hear. I don't know if anyone on the call has sort of thought about or begun any form of health economic data collection or generation of evidence, and it would be good to kind of hear any challenges or issues you've faced with those so far.
Okay, so we have a question about for those companies that can't afford 6 to 12-month projects, is your primary role that's of a reviewer. So that's in terms of the timescale, right? That you perhaps don't have that kind of runway. We can, if that is the case, then we can design our economic models to reflect that, and we can turn around a more basic model in the space of a month or two. I mean, a month is probably a bit unreasonable. I think 2 months is probably the minimum that we can turn it around. But the question is on what is your plans for how you use that model? Are you going to go away and publish it on your website? Are you planning to do a publication? Because 2 months of evidence reviews, KOL interviews, and building of economic models is going to be totally insufficient for that. If it's for internal decision making on better understanding of the indication you should be targeting, or the patient population, or the outcomes you might need to collect in your pivotal trials that you might be designing, or your pilot studies, then yeah, I think a small amount of evidence review could suffice to, shape internal decision making. But if you want to go out and publish and have direct conversations with payers and commissioners, or go to HTA bodies, then those kind of short scale projects are just not going to be long enough for us to do those evidence reviews, and it kind of sets up a bit of risk for both parties if we go about publishing that kind of work. But for internal decision making, 2 to 3 month projects is pretty sufficient.
I think just also to add to that, if it's not kind of within funding capabilities of companies to kind of allocate chunk of funding to a full economic evaluation with the budget impact model or cost effectiveness, we do also often start with a cost calculator model, which is kind of even simpler again. But I suppose that then kind of moves out of the realm of health economic evaluation, becomes more of a return on investment tool with less assumptions, and is a kind of less data hungry. But then as a result is more affordable, but can be designed in such a way that, when funding does come available we can then upgrade that cost calculator into budget impact model or a cost effectiveness analysis. And additionally, I mean, a lot of the work that we do at the minute is actually supporting companies through grant processes. And I think there are new ones coming out, and new rounds of funding from a range of kind of institutions starting in the next sort of 6 months or so. So what we do in those cases is that we support companies with that application, write out kind of a health economics plan as part of that application, and then if the kind of application is successful, an element of that funding is then earmarked to conduct some health economic evaluation.
I think a good extension to that question is from Ashley as well, is coming with about perhaps we should be thinking about just acting as a potential expert overview, and that's something that we can do as well, because with these economic models there are so many assumptions that go into them that can absolutely change the budget impact or the cost effectiveness of the model. So by having some kind of independent overview, that is essentially what Harding provide. They give essentially that kind of independent rubber stamp to say that the health economics makes sense. So yes, you can go away and build some of these tools yourselves. The question is, though, are you going to be able to go to the level of detail sufficient to really capture your economic value? And if you feel like you can, then absolutely, by all means, I think it makes sense to go away and try to undertake those analyses yourselves, and then maybe come to us for review. But bear in mind, there might be things like additional sequelae that might be avoidable with your technology that you might not be capturing in your economic model, or able to find data on those components, or even conceptualize how that would work. So there is always going to be a trade-off there, right? That whereby the models that you could produce yourselves could be quite simple and therefore not necessarily granular enough to maximize the assessment of value that you provide. But then again, if the runway is short and the budgets are short and we don't have access to grant funding like we've just been discussing, then that is also an option where we can provide expert opinion on the models that you might be building in-house. So a comment from Aditya. So I've worked with a couple of algorithms being deployed in hospitals. My focus was mainly on assessing the safety of deployed algorithms. However, the conversation very quickly moved to assessing economic benefit and comparing with AI pathway versus without. That's exactly what we've been talking about today, right? All about economic benefit of a case of the world with the AI and without. And yeah, it's really challenging. I think one of the difficulties is applying health economic evaluations to drastically different areas of the country and even alternative pathway setup. And that's exactly what we've been talking about, especially, primary versus secondary care, although that's potentially being bridged a bit more with ICSs. But it's all about building flexible models with flexible pathways. And that potentially is part of the challenges of when you build these models yourselves, is perhaps maybe not having that wider vision of the need for flexibility in the care pathways and being able to go out and recruit KOLs to review your models and to appropriately interrogate the models from both a clinical KOL perspective, but also a health economic KOL perspective to make sure all the pathways are as flexible as possible. But that being said, the more simple the model, the easier it is to communicate. So you've got to get that balance right between, the complexity of the decision tree and the simplicity of the value messages you're trying to communicate.
I mean, sometimes what we do, I know I've been saying, this kind of contradicts what I've been saying for the past 2.5 hours, but what we do in the conceptual phase is that of an evaluation is that we do map out the value of the technology for multiple care pathways, but build the model in such a way that one care pathway can be focused on and others turned off per budget holder. So that is, again, is a kind of a degree of, obviously that requires kind of a lot of time and resource to do, but it is possible to build that degree of flexibility into the models. And obviously, if we can simplify all care settings into one pathway, which can be possible sometimes when you're purely looking at the economic decision problem, then we will do. But there's always a trade-off between simplicity and building trust in what you're doing with your audience, and complexity and accounting for every kind of detail of variation that you might see in real practice.
Yeah, because you'll get some feedback from a clinical KOL saying, oh, you missed this part, this branch of the tree, or that branch of the tree, or that potential sequela that should be accounted for. But there probably was a reason why you did that. I mean, the availability of data is probably the biggest driver of that. If you don't think the data is available for that parameter, then it's best to try and miss it from the model and the model framework. But the minute a KOL mentions it and gets it on the radar, especially if it's an engagement with NICE, because NICE will go directly to the clinicians and ask for their feedback. And if the clinicians start identifying things missing in the decision tree, then that trust potentially gets lost, because there'll be questions asked about as to why those kind of parts of the decision tree were missing. So that's why it's really important to get as thorough and detailed feedback as possible, run as many scenario analysis as possible, think about the worst case scenarios that might occur when you're engaging with the likes of NICE and other HTA bodies, because NICE's job is to extract the most value for money as possible. So it's absolutely appropriate for them to identify scenarios that could be relevant and potentially damaging to your economic value story. So you need to understand those as best as possible, identify the data points you should be collecting to remedy those and any uncertainty around them in order to build that trust with NICE. And also the KOLs that they will be engaging with separately to the KOLs that you have engaged with.
Any more questions, experiences? I think if not, we can leave it there and give everyone back 25 minutes or so of their working day.
That's great. Thank you so much, Lucy and Trishul, for a great session today. I'm just going to share a really quick slide with some more resources from the team at HDI UK. But firstly, I just want to say a massive thank you to both of you. And if anyone has any questions that they've not thought of today, we will be including Lucy and Trishul's email addresses in the post-event email as well, so you'll be able to reach out to them. So I'm just going to very quickly share a slide with some resources, and I believe my colleague James is going to pop some links into the chat too. But we have obviously the 4th of the Hardian Health webinars is taking place next Thursday, and that's at 9 AM. We also have the monthly newsletter, so if you want to stay informed about what the team are getting up to and what resources are on offer, both from HDI UK and also our wider community with regards to training, you can follow that. And also we're on LinkedIn and Twitter too. And finally, our virtual learning environment Health Data Research Futures is free to access and contains a growing library of bite-sized video training content. And as Lucy mentioned earlier, we will be launching a series of bite-sized videos on the topic covered today and the other 3 workshops in partnership with Hardian Health, and they will be on the platform in the next week. So finally, just thank you all very much for joining today. I really hope you enjoyed the webinar and have a lovely rest of the day.